Welcome to Care Transitions Today. I'm your host, Deb McElroy. This podcast is presented by the American Case Management Association. This conversation is brought to you by Exelis. With your friends and peers at providers across the country, Exelis is building a new framework for how payers and providers undertake utilization review, informed by artificial intelligence, supportive of clinical staff, centered on the patient. When you hear Exelis, think excellence in utilization management. And without further ado, here's today's conversation. We have a special guest joining us today from Hillcrest Healthcare to discuss innovative ways in which she has leveraged technology at her organization. Innovation, which is leading a redesigned care management model and has resulted in improved outcomes. This is a bonus episode in our series on innovation, and we are delighted today to welcome Ricky Moy. Ricky is a registered nurse with 20 years of progressive leadership experience in the field of case management. She serves currently as the Vice President of Case Management for the Oklahoma Division of Ardent Healthcare. And she's at the Hillcrest Healthcare System for the last 5 years. In her role, she oversees the case management program. So Ricky, welcome today. We're glad to have you.
Thank you.
Just as a beginning for our listeners, I'd love to hear a bit about your role, and then we're going to dive right into maybe the setup for understanding the issues and challenges that were the drivers for some of this new innovation.
I came into this company a little over 5 years ago. There was not a lot of case management structure at the division or at the corporate level at that time. Each hospital did its own work as it felt it needed to do. I was brought in to sort of bridge operations, strategy, structure, gap analysis, and all of those things when I was brought into the company. So that's really where I started from, was literally starting at zero.
Okay, that's great. So we're focused today, I think, on the Hillcrest Healthcare System. And can you talk about a bit more about the redesign process and the care management model that you're evolving to?
One of the things I realized very quickly in the division and in the 8 hospitals that I'm responsible for is there was really no structure, no organization, no support. There was no path of processes that stabilized anything.
Okay, so let's get in a little more detail about what the structure looks like today. And can you give a timeline? I know in the introduction you've been at this about 5 years. Those assessments take a while, and really understanding the nuance of each hospital takes a while. So can you give us an overview and a little more detail about what that looks like today?
The first, I would say year and a half was really what I would call the struggle time, just trying to figure things out. Hillcrest Medical Center is a very large, very complex facility. It has a lot of moving parts. Hillcrest South is not quite as large, but it also has a lot of moving parts. There was really, I think one of the first things I realized is as hard as everybody was working to do the right thing and get the work done, the lack of structure was really pretty significant. So in stabilizing structure and getting in policies and doing some basic education and getting in some basic processes, that probably took a good 2 years total. But where the light came on is after that work was done and we still were not able to get things going in the direction we wanted them to go, I literally put my head down on my desk in frustration and said, why? All of my typical tricks of the trade and pretty standardized process improvements were not turning the corners. And when I put my head on my desk in frustration is when I realized that the triad model of case management that we were using was so siloed off that you had people that literally were not talking to each other and they were in their own work streams. Utilization management didn't feel like it needed to be talking to care coordination, and care coordination did not feel like they needed to know what utilization management was doing because that wasn't their job. And social work discharge planning was just trying to keep up. That's when it hit me that those silos, more than anything else, after we had corrected some of the easiest things, it was the silos that were causing the problem. And how did you break down those silos? Because that's a struggle we all have.
It absolutely is. So I'm interested because you've referred to structure a few times, and I want for our listeners to be clear. So you had, it sounds like this, the triad model. Mm-hmm. So you have discharge planning and social work, and you have utilization management and care coordination. How was that defined, or who is that in terms of care coordination? And I should ask, who was it, and does it certainly sounds like the communication is better, but what does it look like today in terms of structure and roles?
Well, I think from what I was able to determine is you had a cluster of utilization review nurses that had their nose in an interqual book doing utilization review. They were calling insurance companies, getting days authorized. That was their whole job. They weren't communicated with or felt the need to understand from a care coordination perspective what clinically was going on with that patient. There was a lot of rote activity that was just get the authorization, get the approved days, Medicare, this or whatever. So from the care coordination piece, they were not communicating well as they tracked the patient's transition of care from admission and making sure they were getting clinically cared for. That was not being communicated over to the social work side that was actually trying to do discharge planning. So what we had, if you can envision in your mind, 3 silos. Think about a corn silo. One is utilization review, one is care coordination, and one is discharge planning and that final transition of care. There was complete absence of communication between those 3 arms of workflow. It just didn't exist. So when I got frustrated and literally put my head on my desk, that's when it hit me. And in my vision, I twisted it, and it became an hourglass.
Okay, so instead of vertical silos.
Correct. It was twisted and became an hourglass so that the resource management was at the top of the hourglass, and we were looking at all of the things we were doing to patients. If the patient is envisioned at the center of the hourglass, and think about sand, the patient's at the center. What are we doing to patients before it ever enters the patient? And then at the bottom of the hourglass, as the sand comes out, you have discharge planning working in the same area as care coordination. So the driver of this refigured is probably the best way to put it. Refigured triad model is that resource manager who is actually in charge of that caseload. And that person is actually the one that is making decisions. This lack of supervision was part of the problem with their current use of the triad model. It's how it got so siloed off. The director of case management was doing the best he or she could, but when they're administratively caught in an office doing everything else they're expected to do, it's very difficult to have that level of leadership on a nursing unit or in a specialty care area. So part of the success of the resource manager role and the right care model has been getting some leadership in that top part, because that person actually is responsible to talk to the care team, physicians and the therapist and nursing and CDI and everyone else involved in this, to figure out, what are we doing? How are we doing it? When are we doing it? Should we even be doing it? In other words, can that not wait until they're outpatient? Are we getting paid for doing this? All of these really critical questions are being asked at the top of the hourglass. And then it goes through the patient in the center. And then the results of all of that in the bottom of that hourglass is what is so important. And it has completely changed how our two largest hospitals function in case management. Completely changed it. Now,
that's impressive. So that's that newly imagined role.
Yep.
With the resource manager that you're describing the function. It sounds like you were leveraging, I know from a bit about your story, there was a need to leverage technology to make this go. So how did that work?
So what we realized very quickly, because we did this new model for a year without really any resources, and it was extremely labor intensive, and maintaining it was very difficult. And that is where the Exelis Cortex platform comes into the picture. I had been advocating for that tool in Ardent, and I wanted to pilot that in the Hillcrest division, because if nothing else in the Hillcrest division, we are pioneers. We are always trying to figure out a better way to do things. And so I worked with leadership and in the company to arrange to have this artificial intelligence and this technology brought in support of this right care model, because the manual labor to keep up with all of this on one resource manager was going to be impossible to maintain, as well as just some of the other things. So what really turned the corner was the Exelis, working with Exelis and getting the Cortex platform, the artificial intelligence, the machine learning. It is literally at the click of a finger. You have tremendous amounts of information. And it's laid out in such a way that a very short glance at it, you know everything you need to know. You're not digging through a medical record trying to figure something out. And that's where it really kicked it into high gear. And that is where we are so successful today.
That's great. So for the folks that are listening, and we have lots of our case management colleagues across the country, can you talk a bit more about what they're seeing on this platform? So you have a resource manager, and what is the scope of responsibility? Are there multiple resource managers or just one resource manager? They go to the platform. What does it look like? I know they're getting lots of inputs and lots of information, but walk us through what that looks like.
It is and this is another reason why the Exelis Cortex platform is so important. It's very easy to use. There are multiple resource managers out across the hospitals. The Cortex platform, the Exelis Cortex platform, is web-based. So I can access it from any computer, anywhere that I am, and pull it up. It is a simple stoplight. Initially, when you pull it up, it's just a stoplight, red, yellow, or green. So it's very visually friendly. It has a very simple trend line that runs through it when you go to the next screen on the patient, and you can just mouse over that trend line and get very quick information. I don't have to dig through a medical record. If my blood pressure on my patient has gotten worse or my white count has suddenly jumped up, it's right there. I don't have to go looking for it. And because that has been key to a resource manager looking at many patients and getting an idea. The system also has a system in it where it tells you conflicts up front. It will tell you you've got an inpatient status order on this patient, but clinically the patient looks more appropriate for observation. This is one you need to look at first, or vice versa. You've got an observation order on a patient, but clinically this patient looks more appropriate for inpatient. You need to look at that first. Those are the ones that I have taught the team you need to go look at first, because that patient's probably sicker and that patient probably needs us sooner rather than later. All of this is done in a couple of mouse clicks. And if you think of it, the standardized way is I may have a list of 25 or 30 patients. I have to go through all 25 or 30 to figure out which one may be wrong, or maybe getting sicker or not doing well, or maybe is doing really well and needs to go. This system tells me within 2 clicks, here's where you need to start. And then here's where you can wait. It helps you set those priorities during the day. It also has a way it can send emails. This is one thing I find particularly encouraging. It has alerts built into it. So it's not, you don't have to be sitting in front of your computer to get the message. If it sees a change, whatever you've told it you want to be alerted for example, maybe I have a inpatient only surgery that's got an outpatient order, and that's not okay. It will notify me any way I tell it to. These kind of things are what changed how that right care model functions so efficiently now. Over the course, even in this pandemic, because we went live in a pandemic, which was very interesting part of this adventure. Over the course of the pandemic, our largest hospital, even with some of the really tough things that have gone on, has been able to take more than a day off of its average length of stay. It's been pretty dramatic improvement. And that translates into I have more beds for those people that need to get in, and I can get them out faster. And this system has helped us do that.
That's great. You've referred to to your model a few times, and I think it's just interesting and I think valuable to the folks listening to just take a pause and just talk about that's been sort of the conceptual framework, it sounds like, for this innovation. So can you talk about that right care model a bit?
We call it right care because when we were building it, I pulled together a team of leaders in case management across the division. And what we did is we borrowed from nursing's the 5 rights of medication administration. So what we decided was to having the right patient in the right setting, getting the right care with the right payment and the right discharge plan. That's where the term right care comes from, is what is right. And we laugh about the right patient because at times the right patient is really, who are you really taking care of? Granny's in the emergency room for the 5th time this month. Is Granny really the sick one, or is there something going on at home? And maybe the grandmother isn't really the patient as much as the patient and the distress is around the family member. That's where the right patient and the right setting, and should they be inpatient? Should they even be in the hospital? The right care model works well in the emergency room because, again, you've got the Cortex platform in the emergency room that gives early information, and it gives you a flavor of what's going on pretty quickly. So that, again, just that leveraging that artificial intelligence and machine learning is what helps that case manager set the priority of who to go see and what do I need to do for this person. And that's really some of the structure around the right care model is, are we getting the care for the right patient in the right setting with the right clinical outcome, and those kind of thoughts around the right care model.
So there are lots of nodding heads listening today, I believe, as you're talking about that. I think that's right. This special episode has been brought to you by Exelis. Leaders like Ricky see how change can remake a stale process to put the focus back on the patient. Sometimes all it takes is putting your head on your desk. Exelis knows and loves the case management and utilization management communities, and we want to be a resource to you when ideas spring to life. Contact Exelis today to demo the Cortex platform, learn more about our work connecting payers and providers, or just run ideas past us. If Ricky's experience is any indication, you'll be glad you did. Learn more today by visiting www.exelis.com/ACMA podcast. And Exelis is spelled XSOLIS. Now, back to the conversation. So you're talking about really some huge wins here. You're talking about reduced length of stay. Can you talk about whether or not the model has improved things on the payer outcome side, right? We have to worry about that.
Yes.
So can you talk about that a little bit?
One of the frequent questions I get is, well, if the payers are using Milliman care guidelines or interqual criteria, why does this matter, right? And that's a fair question, because I will honestly tell you I've asked myself that early on. But here's what's interesting. The tool has something called a care level score. And that care level score is driven by comorbidities of the patient, the current labs, how sick was the patient when they came in, how are they doing right now. There's a myriad of data that goes into something as simple as a care level score. It doesn't care who the payer is. It doesn't care who the hospital is. It analyzes the data and it gives you a prediction about what it thinks based on millions of medical records worth of information. And what we have been able to do is dramatically drop our insurance denials without sacrificing inpatient payment. And that's where people get concerned is, they hear we've dramatically reduced insurance denials, but did your observation rate go up? And the answer to that is no, not really. It really didn't go up. So, our observation rate in some cases went down a little bit depending on the insurance. Definitely it went up in some of the other insurances. And what we've been able to do is work with a national payer to create data around what they were already authorizing and pulling in the care level scores out of Exelis and showing this national payer that, look, 99% of the time when that care level score hit X, you were giving me an inpatient authorization. And 99% of the time when that care level score was on the lower end, we all agreed it was observation. So what that did is that allowed us to start a pilot contract with this national payer. And so what we are now doing is precision UM. And that means, and this is another piece of the right care model on that resource manager bucket. If I have precision UM, then I don't have to worry about dumping clinicals and calling and getting an auth and chasing a fax number or looking at a voicemail, right? The Exelis Cortex platform, the payers can actually go into it and see the same thing I'm seeing, and communication occurs through there. So if that care level score is hit the standard that payer has agreed to, it's automatically inpatient. If it hits the lower, it's automatically observation. And we reserve that gray zone in the middle for the typical utilization review practices of they can apply their standardized criteria. We can do peer-to-peer if it gets denied, write an appeal letter. That stuff, that occurs in that narrow window. But because we've cleaned this stuff up on the two ends, you have opened up more time to do more activity around other things besides chasing an authorization number. It's been extremely successful.
That process, as you're describing it, really sounds like this has had obviously team impact. You're taking that vertical and shifting it to a more horizontal or hourglass kind of image. So can you talk just a bit about how people in the care management team, that including or including care coordination, how they've responded to leveraging technology? Because obviously on the resource manager end, this is front and center, but can you talk about the impact to some of the other team members?
What we've taught the staff to do is to keep their electronic medical record on one screen and have a dual monitor system and keep the Exelis Cortex platform open on the other screen. And in doing that, with that Exelis Cortex platform open on the other screen, everybody can see everything. It's right there. You're not going into different windows in a medical record looking to see if something happened. Because of the way these screens work and that communication is now working, everybody can see everything. And there are conversation bubbles that are built into this system. So if social work wants to send a conversation bubble to the commercial payer, for example, that we have in this system, they can talk about a few discharge planning things right there. I need an authorization because this patient needs to go to skilled. And that's some of that. And the thing about it is that's long documented. That is not part of the medical record. It is part of that system. So that conversation stays there. The care coordinating RN that is looking to see the clinical outcome of the therapy we've just done can see that conversation happening. And then the resource manager who is looking to see, am I going to get paid? When can this person go? What is my next level of care on this patient? It's all right there. And we have the electronic medical record documentation does not waver. That stays in the legal medical record. What we set up is that the utilization review that's actually done in the Exelis Cortex platform now translates over and feeds into Epic in a scan area. So all of that UR information is sitting in Epic, and the discharge planning and these other notes are sitting in the electronic medical record, and those are feeding back over into the Cortex platform. So when you pull up that patient's dashboard and that story, everything is right there in one place. It's been extremely efficient. And again, if I've got a resource manager whose whole scope is to take a look at the big picture, not this caseload, but the whole picture, it's right there at the tip of their fingers.
That's great. And you used the word efficient, and that was the word that came to mind, to my mind as well. I didn't want to miss. I know you had talked a little bit, outside of our podcast about improving outcomes with septicemia patients. So, can you use that as an example and walk through?
So, because, we're always looking, we are never going to settle and say, okay, well, we've solved this problem. We're good now. We're never going to settle. That innovation that is available out of the Exelis Cortex platform is so broad that it really is up to your imagination, or your desperation, I should say, as to what can I do next with this? Well, the thought is, and this is what we're working on now in partnership with Exelis Cortex, is trying to work around septicemia. One of our greatest challenges is the earlier recognition of septicemia, as early as possible. And there are challenges in Epic with accurate recognizing early onset septicemia. So I'm working with Exelis and their team to develop those email alerts that could go to anybody that wants them, that if they see certain Sears criteria start to pop up the second that nurse enters the vital signs, the second the lab is abnormal, the second something shows up, it can fire an alert right away, even if you're not sitting in front of your computer, to see, I better go back and look at this patient, something has changed. So using it for septicemia management, it's interesting. We have taught the physicians how to use it. Obviously, physicians are not case managers, but they understand those care level scores. They understand the difference when a care level score can maximize itself out at 157. That's the sickest of the sick. Intubated, ventilator, drips. 0 is pretty obvious. Well, if a physician says, well, they started out at 130, for example, and today that care level score is 70, which they can see that because we have it rinsed into their Epic screens, then they're going to start earlier talking to a case manager that the patient can go. The flip side, that physician might say, wait a minute, I looked at that care level score and it was 110. Now it's 150. Something happened. And they go in there very quickly. So in using physicians on it, nursing leaders all have access to it. They know how to pull up their nursing units. They know what those care level scores mean. They know how to read those stoplight reports. It has changed how we do bed huddles. It has changed conversations with providers. I tell people, you cannot use the C word with the doctor. They don't meet criteria, so they have to go. No. The conversation is, this care level score has been dropping for 3 days now. Looks like they're probably ready. What do you think? Is a very different conversation with a provider than they don't meet interqual or they don't meet Milliman or whatever. Insert in there. Also with our commercial payers, if we're getting into squabbles with them, I can say, look, this care level score was 90 yesterday. Today it's 120. This patient's getting sicker. And here are the things we're doing about it, to have that conversation. So I do think that by teaching more than case management, it takes a village and that's the purpose of the right care model, is it pulls all of these disciplines in around that hourglass so that all of them matter and that everybody's working on the same information, analyzed the same way. It's changed everything.
That's wonderful. So I'm listening to you and thinking about your journey that you've described and those initial 2 years where, there were changes made, but you weren't seeing the outcomes that you wanted. And just as a leader and thinking about change management and some of the impact that you're now seeing, where it's changing the huddle conversations, where it's changing the provider dialogue, just reflections on maybe lessons learned as having led that process.
Well, I think for me, when I speak about my own personal leadership journey, I've been in I've been in nursing for 41 years and leadership for a long time. What I have learned over the years, and especially over this last 5 years, because we've done some pretty incredible work as a team, is that you have to start thinking outside of the box, which sounds so cliche, if you want to fix the same old problems. And I think for me, just the act of putting my head on my desk forced me to think about things very differently, which seems so simplistic, and it was. Don't be afraid of change. I have learned that change is critical. And as healthcare changes, if we don't change, we are going to get left behind. And the advancements in everything that's going on around us, certainly in the middle of a pandemic, it's critical that all of us push our fear aside and take a hard look and step out and test a water we've never stepped on before. Because if we don't, what are our patients going to do? And if we do, we just may come up with the answer that we need to be what we need to be in that hospital. Because the right care model is not going to work for everyone. It's just not. You have to have, it's not going to work in smaller hospitals. But what it can do is make you think about what will work in your hospital. What would change if we thought about this or thought about that? And that change management and leading a team through change, I've always said leading leaders is very different than leading staff. And leading leaders through some pretty significant metamorphosis, especially when we got a lot of naysaying. It's been quite a journey. At the end of the day, watching them be successful is everything.
So one more comment. So leading leaders is different, I believe. So we have lots of care management leaders across the country who have, as you yourself have had a very interesting last year and a half. But needing to really set ourselves up for the future, and you've addressed that beautifully. But just any additional words of wisdom that you would specifically say to those folks that have been in this space, this care coordination, this care management space for a long time?
Don't get distracted. Don't get distracted. I think a laser focus on solutions is everything. One of the biggest challenges in this pandemic is sort of the hysteria around beds. Make a bed, and things like that. And it's important and it's critical. But I can't solve a problem by making one bed this hour. I can solve a problem by making 30 beds or 50 beds a month. That's what I can solve. And don't be distracted by the hysteria of the moment. Keep your eye on the prize, whatever that prize looks like to you, whatever it looks like it needs to be in your world. Keep your eye on that prize. Yes, you have to react to certain things around you, but do not take your eye on that prize. That laser focus is critical because at the end of the day, it is about sustainability. You have to be able to sustain what you've created. And if you can't sustain it, then it's been an exercise in futility. And you're right back where you were, trying to not beat your head against a wall or laying your head back on a desk.
Yeah, that is a powerful image, Ricky. I have to tell you, laying your head on the desk, I see a lot of nodding heads and a lot of heads on a lot of desks these past months. Well, thank you for those reflections, because I think that's powerful, and I think they're messages that people need to hear. I'm going to circle back as we're kind of in our wrap-up moments here. So as you reached out to Exelis, I know that you were aware of that technology from the beginning. So if other folks are interested in learning more, can you describe what steps you took and what they might do as well?
Well, if Google is your friend, you can start Googling for really any piece of information out there. I started asking questions about automated utilization review tools. That's what I really started with, and found Exelis, and had actually vetted Exelis for a company I worked for prior to the Hillcrest system, when I was working in corporate case management for another company, and found them there. And I will say they had to prove to me that they knew what they were doing. I was not just going to accept what they had at face value. I did my research. And the other thing I did, and I would encourage anybody that's thinking about contacting Exelis to do, is I really questioned some things. I pressured that system. I laughingly tell my boss I pushed it, pulled it, squeezed it, twisted it around, testing it to see if it could do what I needed it to do. Essentially, not so much what they could tell me they could do. I needed it to do certain things, and could it do it or not? And it has not disappointed me in what I needed it to do. So going to Exelis's website and looking at some of the case studies, looking at some of the broadcasts they've done and the WebExes and webinars they've done is really important to understand what can that software actually do. Also understanding that they are absolutely brilliant in listening to new ideas and different ways to use that tool. They are absolutely 100% available to talk about what else can we do with the exact same information.
That is great. I think as you're looking into the future, and I would just comment that I think hand in hand with leveraging that technology was that vision of how you needed to restructure or reformat, and those two things sounds like going hand in hand. You're having some real success with this innovation. Well, as we wrap up, any final comments or final thoughts that you would want to share?
Be brave. For everyone, just be brave. It's a tough time for all of us. And even without a pandemic, if you think about the time before the pandemic, healthcare is revolving and changing. And it's important that we're all brave. It's important that we're brave and we stand our ground for our patients and we get people through this. It's just critical.
Well, those are fabulous words to wrap up on. Ricky Moy, thank you for being with us today. Thanks for sharing your experience, your journey, and your expertise. We are grateful, and I know our listeners will appreciate the valuable information you've shared. We'd like to also thank Exelis again for partnering with us to present this additional episode on innovation. And if you've enjoyed listening to the podcast, we'd love to hear from you. Leave a rating, leave comments, give us ideas for new topics. We really want to know what you're thinking. Until next time, thank you for listening.